Kenya's biggest conversation this morning, the Situation Room. You're just joining us. We've been here with you since 6 o'clock, and now we are getting into some territory that I am very, very impressed by. But before we do that, let's hear today's proverb. Siti Muga.
It's a Swahili proverb from Tanzania. So if I utter words that don't sound like they're Swahili, they actually are. And it also indicates that there's a slight yet significant difference in the way we speak Swahili in Kenya and the way Swahili is spoken in Tanzania.
Okay.
Asisafirie nyota ya mwenzio. Translated into English, don't sail using someone else's star.
Olimma.
See, by the time we get to a point where Ndu is exclaiming in her native language,
it has entered.
It has sung.
Okay. It's a good thing. All right. Entering into this conversation, not to forget, if you're just tuning in, SpiceFM around the country and also online where we are streaming SpiceFM KE on YouTube, Facebook and Twitter. We're going into a scientific research conversation into the medical field. And let me just tell you, I feel smarter than I was 10 minutes ago already, because right now, in person and online, we're in the presence of 3 women who have been making huge strides in the medical field. And today we're having a conversation about the possibility of the use of a single dose HPV vaccine in the country, which is monumental in terms of getting closer and closer to eliminating, or at least preventing to a huge extent, the second most prevalent cancer that affects women in this country and many parts of the world. So, without much ado, this morning in the studio with us, Dr. Professor Elizabeth Bukusi. Good morning and welcome to the Situation Room.
Good morning and thank you very much for having me.
Thank you for being here. And also in the studio with us is Dr. Siovata Kimanthi. Good morning and karibu.
Thank you.
Online, last definitely not least, who's joining us by link this morning because she had to be out of the city, Professor Nelly Mugo. Karibu sana and good morning.
Good morning. Thank you.
Thank you very much for being in the studio this morning. Off the bat, giving that introduction that we did, maybe we can start off with you, Professor Bukusi. We're talking about maybe just some background to this. Last year, maybe 18 months ago, we started to hear the buzz a lot about the encouragement for girls who have achieved the age of 9 or 10 to then go into your health center and get a vaccine, the HPV vaccine, that could then potentially prevent cervical cancer. Cervical cancer, like we said, being the second highest, the second most prevalent cancer for women in the country after breast cancer. And so this was a big deal. You can catch it early. You can get a lot of women who then don't have to suffer from this. And it was that you go and you get your first shot. After 6 months, you get another shot. And then somewhere along the lines there, you get a booster to just then make sure that everything was okay. Now here we are saying that there's a possibility of going in, getting one shot, and you could be covered for life. What and where did you all even start to think that this could be a possibility?
Thank you very much for that really good question. Let me take it back, not just 18 months ago when we started the study. I always find that it's easier to understand these things if you think about it from the point of view of a story. So let's think about what is it that causes cervical cancer. It's not just about an HPV infection. It's about an HPV infection that is persistent. Now, the interesting thing about human papillomavirus is it's the most prevalent sexually transmitted disease worldwide. Many people have HPV, one type or another. It's just that they don't know it. But not all HPV causes cancer. Some specific subtypes cause cancer. But it passes on very easily. Condoms don't even prevent it. Intimate contact is what allows for HPV to pass on from one person to the other. So once people become sexually active, both men and women, HPV passes on within populations. And when there is persistent infection, that is what years down the line, because of the changes that happen at the cellular level of the cervix, women end up having cervical cancer. So work has been done, and many people have committed many, many years of work to being able to find these vaccines and then make clear that we need to immunize. And of course, the goal was find them before they're sexually active. Between the ages of 9 to 13. If you can catch them there, make sure they get vaccinated. And as you're saying, get the first dose, a few months later, get a second dose, a little bit later, 6 months or so after, get a booster, and then that would help prevent cervical cancer. In countries where they're resource rich, it's not just the young girls alone. Even the young men get targeted. Remember, they're partners in this, transmitting from one person to the other. So that then brings us to the 18 months you were talking about. And I think this would be a good time for Dr. Nelly Mbugo, who was really one of the brains behind the whole study, to tell us what made them really come up with this idea that we must do this study.
Indeed, Professor Mugo, why even dream? I mean, how dare you dream that, something like this could be? What put it in your mind to say, or in the minds of yourself and the other team who started to work on this, that, we could get it, done in one shot and then actually start the work on this?
Thank you. And Professor Bukusi has really started us off very well. And I want to say she's my classmate, so we've walked a long path. So all this thinking happens together. So there's very strong data, from previous vaccine programs. One of them in India, where girls were expected to take the 3 doses, but for several reasons ended up with 1 dose. So in a group of about 40,000, specifically to the India group, they had about 4,000 girls who ended up with 1 dose. And they've been able to follow up that group to see how well protected they were. 3 doses, 2 doses, 1 dose. Though the plan was for 3 doses. And now they've actually published data very recently, and they had published before for up to 4 years, that the girls who had received 1 dose had continued to be protected compared to the girls who did not receive any vaccination. So it wasn't just India, there was also work from Costa Rica and other trials that kept showing up that people who received only 1 dose had some level of protection. Now, why wasn't that enough, you might ask? Why didn't we just move on and say, we already know? But we don't know if what we didn't know, what we call observational data, is if the girls who received 1 dose were different from the girls who had no vaccine or the girls who took 3 doses. I mean, even your behavior that makes you take 1 when you should have taken 3. Could it be that your social life has lower risk? What is it? What are the differences? So to answer this question, it was necessary then to have what we call a randomized clinical trial. In a randomized clinical trial, it's like throwing your coin and it's either head or tail.
Right.
So it's a chance which group each person ends up in the vaccine group. Whether you get the vaccine or you don't, the selection is random. And then we look and make sure that you're all the same in your characteristics. I hope I've answered. And I want to say, actually, there are several other single-dose trials which have gone on globally. There's one called the Doris trial, which was carried out in Mwanza next door. But the Mwanza trial was for girls ages 9 to 14. There was also a trial in Costa Rica, and there was some work in India. So we have a collective data for answering this question.
Okay. And Dr. Kimanthi, right. Dr. Kimanthi, where are we now? Speaking Kenya specific, with all of this so far, at what point are we in the country in terms of the research and then possible rollout of the same?
Thank you. So currently in the country, we already have a rollout of the HPV vaccination for girls who are 10 years. I think this was rolled out, 2 years ago.
Yes.
And basically, it's just about the uptake and ensuring that girls who are 10 years actually get vaccinated. Yeah.
So in light of this possibility of the one shot then, Prof, and maybe girls who had started, I remember taking in my daughter for the first shot, maybe she's due in a few months for the second one. So what happens if you've already started? Do you then still continue? I mean, where are we then in the timeline of all of this operation?
Really good question. The challenge is there are committed parents like you who took your daughter for the first shot and who will take her for the second and take her for the third. The majority of individuals, even getting that first one is a problem. Our coverage is probably around maybe 15, 20%. We need to get to 90% and targeting these young girls between the age of 9 to about 13 before any onset of any sexual activity. That was the target. So the majority of them may not even get there. Nobody's taking them. No one's even getting them the first dose. If you've started, I would say until policy changes, because what we are going to do is keep talking about it and pushing for a policy change. Policy change usually comes at different levels, at a country level, at the global level when WHO meets, and there are committees that are set up to evaluate the data and then give global guidance. But until that happens, I'd say go ahead and get as is the current policy. But the important thing is that now we do know, and now you can be assured that your daughter does have that first dose, she's in good shape. The encouragement should be, can we even get more young ladies, more girls to get vaccinated? They really do need to get it.
Yeah. What's the barrier? Where is the vaccine being administered? Now you're talking about that age. That age, of course, requires the parents to come in. Is parental consent required? Can it be administered through the school system? Because the presumption is that all the girls that age would be in school. So what's the barrier? Because 15% is extremely low.
This is a good question for Dr. Siavata. She's closer to that age group.
So basically, first question, where is it being offered? It's at public health facilities. And that's where our young girls should access it. And you've asked about barriers. And I think Prof. Bukusi has already really alluded to quite a bit of it, that for these young girls, they are dependent on their parents. And so they require a parent to take them. And so if a parent is not available, or if a parent is not aware of the importance of the HPV vaccine, if a parent is maybe even anti-vaccination, then there comes a challenge. And then there's probably that parent who, if they got the information, then they would be very happy and willing to take their daughter. But then the question is, do they have access to a public health facility nearby? So those are some of the challenges.
So how widespread is the availability of the vaccine? And then, of course, this is reproductive health. And you can imagine parents being told, take your child for a reproductive health-based vaccine. Imagine that implies sexual activity.
Well, I think that was one of the arguments.
That's the biggest point of resistance. So how are you working with that? Is there education? Is there a policy to support it?
Maybe it's something that maybe everybody all three can chip in on, because this was one of the things that came out when the rollout happened, and there was this hue and cry from very many saying absolutely not. Essentially, what you're saying is that if you go get the vaccine, then you have the free, liberty to then go out and then engage in any kind of sexual activity. But this is what a lot of parents. This is what a lot of parents had an issue with.
Isn't that where the public education would come in?
And whose responsibility is it?
Well, I think it would be if government has a solution to help society, you need to recognize where you're meeting society. So this child cannot take herself into a clinic. It is, unless it's going to be administered through the school system, it's the parent you're targeting. So it's the parent that you need to work on through the church, through religious institutions, through institutions they understand. But it's the public, it's the health, it's the public
whose
education.
responsibility is it?
Good question. And I like your discussion because I think this is part of your role. I want to throw it right back to the three of you. Educating the public and letting people know. Saying that the moment you give a young girl vaccine is like giving them the license to go and have sex. Is like saying, in fact, we shouldn't even be using seatbelts. Same argument. Because if you're using a seatbelt, that means drive badly and have an accident and kill yourself, because the seatbelt is supposed to
Well
protect
put.
you. It's the same argument. So does using a seatbelt give you the license to drive badly? It doesn't. And coming back to the issue of whose responsibility is it? Sexual education is the responsibility of parents. And it is a responsibility, sadly, most of us, and I'm a parent myself, do very badly. Sex is this one thing that most people do, but don't want to talk about it. But we're all evidence that it happened somewhere. You and I being here, sex happened somewhere.
Yes.
So it's the one thing people don't really want to talk about. So it is a responsibility that parents need to take on, because the greatest, and this has been looked at world over, the greatest influence to young people making choices about their sexual activity is actually the home. It's what they hear, what they see, what they're exposed to. The conversations at home make the biggest impact, even though peer pressure makes a difference. Those who are able to stand against peer pressure, it's because of what they have learned, what they have seen, and the atmosphere at home that is allowing them to be able to make decisions.
Can I just revisit that? And I agree with you. On the responsibility, this is a medical intervention coming from government. What is government's responsibility in public education around health issues? Because you need to reach that parent. And I think media has to be a partner, but surely government has a responsibility. I think in other countries, I think in Kenya, the public education role of government and health systems is maybe less than in other countries. I mean, there are other countries where any intervention that government is going to make is preceded by civic education. So, for instance, in the County Government Act, there's a whole section on civic education and the responsibilities of government. Now, this does not in any way replace the responsibility of communities themselves and of parents, but government surely would be the start to give the correct information, to target the parents, and to target those who then target parents, so that parents can do their role. So isn't it a joint responsibility? But where does it start? And has it started?
Hard question. I'm sure Professor Mugo would love to jump into this conversation. But even as she jumps in on it, I think talking about government responsibility, we are part of the Kenya Medical Research Institute.
Yes.
We are a government agency, semi-autonomous government agency. This is part of our responsibility, and that's why we're here speaking about it. So Dr. Mugo, Professor Mugo, please tell them, where else is government responsibility?
I was going to start with the issue of sex stigma, but I'll come back to government, which is what Professor Muthui was speaking to. I think, and she has already brought it up on who is government. Every civil servant is a part of government. But I think what you're alluding to also is a purposeful, intentional process of public education on really key important public health issues. And, for many years, the issue of sex education has come up in Parliament. And as a reproductive health specialist, I've not been happy with what they have returned to us. And what I've observed very often is that the bias in Parliament is similar to the bias in communities. This fear that girls will have sex.
Yes.
Well, I don't know if there's any fear that boys will have sex. I feel like we have a very muddled system.
It doesn't come up.
We have messages for boys to go and be boys and the girls to be, what's the word for it, virtuous?
Yes.
And I call it sex stigma. We all want our little girls to find that husband and bring us children, but we don't want to talk about sex and we don't want to prepare them for safe sex. So in reproductive health, I think the bigger question is, how do you, as Professor Bukusi mentioned, how do we prepare our children to transcend from their adolescent years to their adult years safely to achieve their sexual health goals, which all parents, I believe, desire for their children. When I talk to most young women, by age 30, they're being asked, where's the husband? By age 18, what are you doing with the boy? So how we transition them and whose responsibility that is a huge, I mean, it could fill up many books. But coming back to HPV and the stigma against HPV and the alluded negativity of messages around sexuality, and therefore even stigma towards cancer is something we need to really as a community look into, and government alone will not solve that. I think between media, science, stakeholders at every level and parents to protect our communities, we need to engage in this, recognizing, as Professor Bukusi said, we're all products of sex. We're looking for the next generation. That's how they'll arise. But how they do that safely is when now the medical intervention come in.
We're having a conversation about the possibility of a rollout of a single dose HPV vaccine in the country. In the studio this morning with Professor Elizabeth Bukusi, Dr. Siovata Kimanthi, and Professor Nelly Mugo. Who's involved? How should government be involved in this, hand in hand with media and other stakeholders? How does this conversation then be brought to where it's important, and we go back to, or rather we cross over that dismal 15% of penetration when it comes to vaccine administration in the country?
One of the things that people who have been in reproductive health research have found over time is that a lot of the success or the failure thereof can be, should we say, attributed to the absence of male involvement, involving men. Now, Professor Mugo, you put it well. The discussion around sex, girls, women. How then is it that this study, we only have women PIs and co-PIs discussing an infection that we know is contributed to equally by men and women?
Gender representation on the panel.
Dr. Mugo,
For future
I'm directing this as
consideration.
you. I know you're going to pass the back on to Professor Bukusi at some point and Dr. Kimanthi, but let me hear your views on this one first.
Charles Muga, you've caught me right there. I wasn't prepared for that one. It sounds
Nelly,
like
the
you've
idea is
looked
not
at
to
the
make you
question.
uncomfortable, it's just to get you thinking.
You know, very often the people we have on the table in a lot of these forums is an all-male representation. Don't you think it's a good break? When women rise to the occasion, take up leadership, and deliver. I've never had anybody asking, when you have an all-male forum, where are the women? Are you asking us today, in Kenchi, where are the men?
Oh, we ask that question here quite a bit. Yes. When you have a forum and you can see all men, we say, we ask, how is it? So we are now asking the question of the women.
Or maybe coming from the point, Professor Mugo, that, you know, for you know, men that are involved in this process, whether you want to look at it or not, how then as stakeholders in this conversation to get more people vaccinated, why are we not seeing their involvement more?
Actually, we did some work some time back. I did a study in Korogosho and in Kajiado. And that was about the time we are preparing for vaccination in country and on a global level. And we interviewed mothers, men, boys, young women. And it's interesting, the boys in Korogosho and in Kajiado, they told us that if you don't involve us and tell us what this is about, we could very easily be the ones who start saying girls shouldn't be vaccinated, and girls will listen to us. So, Charles Muga, you're right. Women do listen to men a lot, and men have a lot of power over what happens in women's lives. I've also often said that if this was penal cancer, vaccination distribution would be very high. We probably wouldn't be talking about do we need resources or whose responsibility is it to educate. But it's a woman's cancer. Most HPV, I mean, men do get oropharyngeal cancer from HPV infection, but the highest burden and the biggest hit is on women and in cervical cancer. And I want to say that We estimate about 300 women die every month in Kenya, which is about 8 every day from this cancer, and there are deaths that need not happen. So the discussion is, who feels strongly enough about this to do something about it? So I think if we talk to both men and women and children and get the message right, I think we want to protect women, because the health and well-being of women is the foundation. What is it called? It's the brickwork that holds a family together. Is it the most? I'm not sure. But I think and Charles, you'll agree with me, I don't know what you men would do without women in the world.
Professor Mogo, can I ask, from a policy point of view, where is the gap? Why this 15-20% when the vaccine is there? Is it adequately available? Where is the knowledge gap? Because there is the medical knowledge that has then not gone into the community. Of course, there are beliefs around it that need to be dealt with. But to overcome that, the gap needs to be identified and remedies need to be identified. I mean, media sensitization is one, but this kind of forum may not be enough unless we understand where is the gap. Why? What? If I was to draw a parallel, childhood vaccinations are administered from the lowest community health unit. From the moment a woman goes into antenatal, she's tracked, she's advised, and that process continues up till, I think, is it age 3, age 4, when the last vaccines are being administered, and they are followed up at the community level. So where is the gap with the HPV?
I think you've come up with a really good question. Being a scientist, I almost wanted to convert it into a scientific question, but for this forum, as you were talking and I was thinking about it, what I would say is taking examples from where we've had successful implementation and coverage. And Rwanda is an excellent example. Right, the vaccine efficacy was proven in 2007. Around 2008, 2009, there was a program to provide free vaccines for programs and governments in Africa. And Rwanda took it up. But Rwanda implemented a school-based program very successfully, vaccinated all their grade standard 4 children, and then moved on and did catch up to Form 3. And the data we're seeing from Rwanda for that population, they literally have no HPV compared to people who are not vaccinated. Another success story actually was in the Kenya demonstration project, which took place in Muthui. Uptake was extremely high, so much so that the ministry had to go and buy additional vaccine to vaccinate the next community. So what happened then when we started doing national launch? I think it's a big question. And it's this issue you brought up again: community education, awareness, engagement of the right stakeholders. Who do people listen to? People listen to their teachers. Having a school-based versus a clinic-based program, how do we reach parents? How do we inform them? Because all these people want the well-being of their children.
Indeed.
And we all want the well-being of our female population. How do we get away from negative messages like vaccination will make you infertile? Now, we know that's not true. Ask Dr. Tiovata how many of her girls got pregnant in spite of access to contraceptive, more than we would have desired. So we know those things are not true, but they are being constantly perpetuated, and the community believes them. So we need to work against it. One final one I want to say for us, so that we don't beat ourselves too much. The US was very low on uptake at the beginning. They kept at 15 to 20%. For a very long time, and they had all those issues of what I call sexual stigma, but they've overcome it. And I think we can too, but we need to be, I think as you're pushing, we need to be purposeful about it.
Indeed. Dr. Kimandhi, I think one of the things that we hear oftentimes, value of having CT in this room often talks about peer education, especially as concerned HIV, when that education was, when those campaigns were really hot and heavy. And then we hear that, these girls at this age are probably at the very center of how emphasized peer-to-peer education can be, because it's at this age that you're listening to your peers, you're hearing what they're doing, you're getting influenced by their actions. How do you see that playing a role then in getting others to basically jump on this and then get vaccinated?
So that is a really, really fantastic and important observation about adolescent girls and young women. The peer influence is really, really high. At our site in the clinic, we often see that the girls come in groups. So even when we need to schedule them for appointments, we have this sort of arrangement where we know that a certain group moves together, and if you want to ensure that they have good follow-up and they keep on coming for their scheduled appointments, then you need to book them all together. And better still, even have the goodwill or attention of the group leader. And where peer influence comes in, I'll give you a small example. COVID happened, and that sort of like disrupted quite a number of activities and even our study activities. And one of the things that we did just to try and make sure that we're not going to lose these girls, because for a while there, physical visits into the study clinic were not happening. So we set up a WhatsApp group. And in this WhatsApp group, it was just basically for our kinship participants, for those who are able to access a smartphone. And we came up with a couple of rules. And within this WhatsApp group, one of the things that we saw is that we actually had an increase in contraceptive uptake amongst our participants, simply because of the fact that they had conversations with themselves. It was not us pushing them and saying, we would want you to have a better choices, sexual reproductive health, blah, blah, blah. When it comes from us, it's like we are talking at
Down
them,
to them, yeah.
and talking down to them. But when this conversation moved to their group, and we have no peer influencers, we saw that there was an uptake, for example, an increased uptake in, say, in methods to prevent pregnancy, and an increased uptake in PrEP, which is, something that, is useful in preventing of HIV. So yes, if this message about HPV vaccination could also, we could also find a strategy, maybe as even Dr. Mugo has alluded, in Rwanda, the school-based program was working very, very well. So maybe even here in Kenya, now that we are aware about peer influence and things like that, maybe a good strategy would also be at the community level, have some peer champions, that sort of thing, and have, peers for young women and young boys and young men for the HPV vaccine, speaking about it to each other. I think that might also, go a long way.
From a government policy point of view, you have described public participation very well. And it's actually getting to the heart of it, because in the absence of understanding the dynamics between, say, the population that you want to work with, and understanding what their influences are and the triggers and things that make them tick, in fact, that entire process could become tricky. As you were speaking, there's something that came to my mind. When you spoke to these young people, what are some of the things that they mentioned to you as being problems and hindrances towards either accessing or simply understanding this whole process that you had introduced them to?
Okay, so for quite a number of our adolescent girls and young women, one of the things that we have to respect is the influence that their parents have over them. So for where a girl thought that the HPV vaccine is a fantastic thing, but a parent was not on board, then that is a challenge. Another thing that we have also identified also is just lots of myths and misconceptions within the community surrounding vaccinations in general, a lot of anti-vaccination messages, lots of myths about just surrounding sexual health and reproductive issues. And so those are some of the challenges that we found, where a parent needs to be on board, and where also there are quite a number of myths and misconceptions about, HPV, what it is, vaccines, and what they do and what they do not do.
What are some of the more popular myths and misconceptions? Just a few.
One of the myths and misconceptions that we came across as far as the HPV vaccine is concerned is that, one, it will make you infertile. And we had many participants who, even after they received the vaccine, were sort of like really, really worried about the possibility of getting pregnant. And another challenge is also, just to mention, their partners. If a young girl's sexual partner, who is usually older, is not for an intervention, chances are the girl will not take it.
Influence.
Yeah. Can I ask a question? And it's just an open question. I'm hearing in the conversation and understanding you're coming more from maybe the research perspective as opposed to maybe the government policy perspective. I'm hearing a lot of focus on the girl and not a focus on the parent. And the parent seems to be an influence. Whereas and so my question is, in terms of healthcare, what's the role of the parent vis-a-vis a girl of 9? And shouldn't the intervention be framed around that, as opposed to considering the parent as just an influence? And then on the maybe economics of it, are we saying that the same vaccine, the single dose would be of the same particular vaccine? And for me, economically, I'm thinking, lessons in COVID. Where is this being manufactured? Where is Kenya on this vaccine manufacturing? We know India has gone ahead. We know we have the brilliant minds. We're really proud of the work KEMRI does. We're aware it's not funded enough, But where are we on that? And sorry, I'm asking two joint questions. Yeah.
It's great you're asking two joint questions, and you're asking the questions that I'm so glad you asked, because this is a great opportunity to say, please fund KEMRI more. Please fund us more. Please fund the universities more. You asked, where are we on the manufacturing platform? We don't put enough money into research to be able to manufacture. We just do not. We're doing a good job that we've started giving Kenyan researchers money for research, but it's a drop in the ocean. We need so much more. And if we want to get to be part of the manufacturing giants in terms of research outputs, we have to put in money. There's no shortcut to it. The kind of state-of-the-art laboratories, manufacturing facilities needed, it just requires putting money into it. But I want to answer the other question. I may not answer it satisfactorily, but that you asked about where are the parents, where is the role of everybody else? I want to take it back to, we keep talking about UHC, universal health coverage. The one part that we forget is the promotion of health and the prevention. It's not about people coming to a healthcare facility to access health services per se. It's about what you've been pushing. How do we give them information, keep them healthy? By the time they're coming to your health facility, we've already failed.
They're already sick.
They're already sick. They already have a problem. The first prong should be, how can we ensure they're keeping healthy in all aspects? Physical, mental, sexual, all the things that matter. Then the second one is the preventative, where now the vaccine comes in. Make sure that we're giving them state-of-the-art products that prevent specific things that we already know will be prevented by interventions. The third aspect is what we keep focusing on. Make sure they have a card, make sure they can come into hospital. But by that time, we've already failed them because they already have developed something that now requires a major intervention. So even the focus of our UHC should be that, promotion of health, prevention of ill health. And then the third part is where people come in for an intervention when they already have something that's wrong with them. But as Professor Mugo was talking about this, and I think maybe she could again add something about it, can we change the focus of where people get services? And it's something we're thinking about all the time when we're talking about HIV, when we're talking about HPV, when we're talking about other sexually transmitted infections. People don't always want to go to a healthcare facility. They don't want to go and see sick people. They don't want that smell of antiseptic and all other bodily functions and all other,
or tell somebody your history when somebody else might be listening.
people don't want to go there. How can we make, if they don't need to, when you need to go there, you need surgery, you have to go. There's no option. But if you don't need to go there, how else can we make it possible for you to get these services?
What else can we do, Professor Mugo, even as we're looking at this? What else can be done to make it so that that uncomfortability factor is removed and people are still then getting what they need?
I think I can go back to emphasizing what Professor Muthui has said. We are very focused on treatment, so we have health.
Professor, we can't hear you very well. Maybe we just need to check your line on that. All right. So, I mean, even as we're continuing and getting that audio sorted out, what the focus then needs to be as we are moving forward and saying, okay, and voila, you're back, Professor.
Yes, community. The linkage between the health facility, curative services, and community. So how well do we serve people in the community? The second ball is preventive medicine. How willing are we now on policy level actually to support preventive medicine? And as you said earlier, we've been very good on childhood vaccines. Can we go beyond childhood vaccines and resource prevention? But I think one time I listened to somebody from Treasury talking to us at ANAC, National AIDS Control Conference. And what he said was, we don't speak well enough to the cost effectiveness, the savings, which would be accrued from prevention. If we didn't have cervical cancer coming into our cancer unit, how much more money would we save? So that we're not just talking about, give us this money to do this, we should also talk about, this is how much you'll save. And maybe we in health need to adapt the right language so we can be heard by those who carry the deep pockets to resource the places where we know that the resources need to go to. And that's preventive medicine.
Indeed.
And again, community, our focus when it comes to health on community before people get to the hospital. So taking these services to community and resourcing that point of delivery.
Indeed. It's a conversation that cannot stop. I mean, I think that's one of the first things that we looked at when we started this conversation, that it needs to be something that continues from community to, the medical fraternity, to research, to, up the chain until, we get to the place where that coveted 90% has been reached. And we can't stop talking about it. Professor Nelly Mugo, Professor Elizabeth Bokusi, Dr. Siovata Kimanthi, thank you for being in the room with us today and at least, spearheading this conversation. And, kudos to the wonderful work that's being done. And it would be good to be alive to see the day when we are seeing that this is spread across the country. Thank you so much for being part of this conversation this week on The Situation Room.